This is for hyperopia. Again, it's quite obvious that the cornea is steeper in the center now and is flatter in the periphery. Again, in attempts to simplify this thing, Luis Ruiz from Bogota, Colombia, introduced the ALK, which is the automatic lamellar keratoplasty, and this was used for myopia. And again, in this case, he had a self-guided microkeratome. It had little wheels and tracks that it worked on, and it was so made that the two cuts were made. The first cut, which was the larger, made a hinge, or else not hinge cap. Now a second cut was then made, which was smaller, and according to the amount of correction you needed, was also a certain depth. Therefore, when you put the original cap back on, there was now, let's say for myopia, a divot in the center, and the cap would fall in the divot, and it would be flattened, and this would be used for myopia. Now for hyperopia, it was just using strictly the microkeratome. And what Ruiz did, unfortunately this was very short-lived, he made an extremely deep cut with the microkeratome, and depending on the amount of correction of hyperopia you had to correct, he produced what was called a controlled ectasia. I put controlled in a quotation marks because I don't really think it was very controlled. The advantages, again, he did invent the self-guiding microkeratome. The visual recovery was quite rapid. The cost was not now the cryolave and the microkeratome, but simply the microkeratome. The disadvantages, very small optical zone, and not as accurate as the current techniques. For the hyperopia, fortunately I did not do many of these because I think we created too much of an uncontrolled ectasia, and it again was not accurate. And this is the microkeratome. It has all these little wheels and tracks, and by moving the plate up and down you can control the depth and the thickness.